for the advancement of health communication. As many of you already know, our aim of the Centre is to connect researchers with clinicians and to reach out to the community and find ways to improve health communication in all its forms. My centre has established a memorandum of understanding with the Faculty of Health and Behavioural Sciences at the University of Queensland in Australia. And one focus of that MOU is interprofessional communication in healthcare. I've been working closely with Associate Professor Neil Cottrell on this important topic and was delighted when he recommended our speaker for today, as she has strong affiliations with the University of Queensland, and I hope the connection can extend to our centre. Dr Lynne Sinclair, our speaker, is a physiotherapist and senior consultant, partnership and innovation at the Centre for Interprofessional Education, and holds an appointment as assistant professor in the Department of Physical Therapy, Temerity Faculty of Medicine at the University of Toronto. In 2017, Lynne was appointed an adjunct associate professor at the Faculty of Health and Behavioural Sciences at the University of Queensland. Lynne has wide expertise and has publications in integrated care, quality improvement, patient safety, intersectoral communication, and team-based practice, all things that are very important to me. Lynne has been honoured with multiple awards for teaching and healthcare education excellence, and she sits on the board of directors of the Canadian Interprofessional Health Collaborative. I'm very excited to welcome Lynne to give us a talk today. I have great pleasure in welcoming Dr Lynne Sinclair, who will be giving an interactive workshop called Advancing Collaborative Communication for Safer and Healthier Teams. And I'd like to say over to you, Lynne.
Thank you so much, Bernadette. What a warm welcome. And thank you so much for joining us early in the morning for many of you. Yeah, I'm really honored to get to speak to you about a topic that's near and dear to our hearts, which is really talking about how do we advance our teamwork together. And to do that, I want to frame this within a collaborative communication for safer and healthier teams. So my hopes for this talk, I want you to have a perspective on some competency-based frameworks, what some of the evidence and wise practices are in collaborative care. I want to also get you excited in your various roles as leaders, clinicians, faculty, researchers, in what we need in the system or where the system is at currently to really support those safer and healthier teams. It's also critical that we think about sustainable success and how we can keep this within our curriculum, in our research platforms, and in our practice. Whenever I hear someone speak, I listen to their formal bio, but I know that they hold certain perspectives or biases. And these are some of mine. This picture shows my lovely mom, my beautiful daughter, and my stunning little granddaughter. And so my biases are that I'm a clinician. I've practiced clinically in cancer care, rehab, and orthopedics. So I bring that reality of our system. I've worked as an educator and a leader administrator, both in hospitals and universities. So I bring that interface. I've also, as Bernadette outlined, done a fair amount of writing and research. But maybe more important is that I'm a parent, I'm a patient, and I'm a citizen of the system. And that's why I like to study in this field and want to really promote this across our global audience. This is what we're talking about. This is what we're hearing from families, from patients, from caregivers. I'm stressed and I don't understand what to do. The social worker tells me one thing at home, the doctor something different, and the nurse has another goal. We're a busy family. I don't have time and I don't know how to do all these conflicting things. The only thing that matters is that my wife gets well. So whether or not we are talking to each other behind the scenes, if the perception is that we're not working as a team, we are not doing our best service to our patients and their caregivers and family. So terminology, there's lots of different terms that we talk about when we're using this field. The definition of interprofessional education that many of us use globally comes from the World Health Organization. And it's this: when two or more professions learn about, from, and with each other. So if you remember nothing else that I talk about today, I would really ask you to remember those three words, because if we can learn about each other, from each other, and with each other, then we're doing better collaborative care. We also look to the World Health Organization for a definition of what is interprofessional care. And they've really gone very broad with this description to extend it to all health workers in the system. So that includes the receptionist that answers the phone when you're trying to get into your primary care practitioner, your nurse practitioner, or family doctor, your GP. But it also includes, in our healthcare system, those people that are working in support services, delivering meals to our patients, cleaning the floors, and housekeeping. So it's really this entire system of workers that work across settings and across to really deliver this comprehensive care. Now, we often use the word team, and I think it's important to redefine what we mean by team. And we love this definition by Attenbach and Smith that talk about that it's really a small number of people with complementary skills committed to a common purpose, and that they hold each other accountable, mutually accountable. So the members really are interdependent. We know that there can be a lot of fluidity with teams. We have people coming and going that work multiple shifts or only work part-time on a unit, but the team has a common purpose of what's pulling them together. Usually it's best and safest patient care. So I'd love you to just pause for a moment and reflect, for you personally, why is collaborative care important? Why is it important to you, your work, your patients or clients that you work with, or perhaps broader to your community or organization? And while I continue on, I would love to see a few of those comments in the chat. If you felt comfortable just briefly summarizing why collaborative care is so important to you, it'd be nice to see some of that dialogue. So why we talk about this and why interprofessional practice is truly so important is because of this. When one person is not enough, when there's a lot of complexity in our system, when there's lots of healthcare workers involved, what can happen is on the left-hand side of the screen, where what we really get is more parallel play. We have wonderful clinicians doing great assessments and great interactions, treatments, but really doing it in solo with the patient and client, maybe occasionally talking to each other, creating a solo or personal care plan. What we really want to see is what sits on the right-hand side of the screen, where we have those same clinicians doing fabulous assessments and treatments for what purpose? That common purpose of an integrated shared care plan. And that's where we really need this, is when there's that increasing complexity. So we see this as most important in areas like mental health, chronic disease, geriatrics, pediatrics, where there's naturally a lot of healthcare workers in our system. When we think about team and when we think about it, we need to think it from the client or the patient's journey. It's their healthcare journey. They don't see us as separate teams. They see us as this is one health journey. So we need to think very broadly about team to truly be between teams and between organizations, as well as just between people. I'm just going to pause and look at the chat because I see some nice comments coming in. Thank you for sharing. Melanie, shared understanding, mental models to shared problems. Beck is saying, yes, values-based healthcare. Naomi, thank you. Understanding each other's perspectives and ensure you are working toward a common goal. Bernadette, thank you. Yes, they must be all on the same page and have the same information. watching out for that miscommunication. Hi, Kate. Oh, thanks for joining. Wonderful. Oh, look at that. And it makes staff happier. Well done, Kate. That is huge. Yes. So if this is a little bit new to you, you're likely saying, okay, Lynn, what's the evidence? Is there evidence that this actually makes a difference? And it's a loud and clear yes. We have large synthesis reports that have really been pulling together what we see from across the globe, including the World Health Organization. And I've pulled out a few things here that I thought would be of interest to you. So in their report, they've pulled to say that improved collaborative working together improves length of stay, tension and conflict in caregivers, reduces client complications, and it reduces staff turnover and hospital admissions. And there's the link with safety. There's our clinical error rates and lower mortality rates. So there's huge data in almost every patient care population. For those of you that are working in a research space, I would encourage you to explore some of these great reports that pull together a lot of the data, including the Cochrane database of systematic reviews. We're also now seeing a huge shift coming out of the pandemic. This has been a very, very challenging time for our systems. And wow, has it ever given a resurgence of a focus on collaboration? Because what we're seeing is there's a new normal where healthcare providers had to be redeployed. There was new rules and shifting scope of practice for new conditions that we didn't even have a care plan for. We've also had to really shift our thinking as organizations when we're seeing teams really impacted by stress and burnout and attrition in our field. We've also, of course, had to pivot much more to virtual communication, and that includes in team meetings. So thinking very thoughtfully around how do we communicate virtually has been a real shift. We've also had a lot of isolation for communities and for families, which has created more conflict and more challenges with leadership on who's leading what aspects of care. One of the interesting things for me in the work that I do is to really start thinking about, is this a little bit of a silver lining in some ways? Are there ways that we can really learn from what we've just lived through? Because a lot of organizations are actually saying there was more cooperation and collaboration and more fluid boundaries between roles that happened during the pandemic. We also know that there's been some great innovations with technology, students that have really embraced virtual learning, and there's been a lot of rapid transition to thinking about best approaches for everyone to be learning in a variety of innovative ways. So this is a wonderful new publication that's come out, and pleased that some of our Canadian colleagues were a part of this publication. So for all of you researchers, what can you do to help in the field? Well, we are still really interested to know, we clearly know now that improved focus on care, interprofessional care improves health outcomes. We still need to work a little bit on the connection. If we teach this to our students, where do they go and practice, and how does that improve our care? So things like, we know the what, but now we need to unpack the how and the why. And I think the pandemic has elevated that to us. There are different ways of learning and functioning as teams. We're really hearing a call for more including patient and family authentically and caregivers authentically. We need to continue to purposely align education and health together. And it always amazes me the number of organizations that haven't been intentionally doing this. And I'm so pleased that University of Queensland is one of those that is. They've been really working at building those delivery systems to work in partnership. A clear example is when our students go out to do clinical rotations, they need to have clinicians that are able to teach collaboratively and be able to role model this, so that students see the connection between what they're learning in theory and what's happening in practice. And then maybe a big star on the bottom point. We continue to want to have more mixed method approaches where we look at economic analysis. The pushback will always be, oh, it's too challenging to schedule in, it takes too much time, the logistics. So we need to continue to support our research that a time investment up front actually saves time and money for organizations in the end. We know that this is actually complicated. Quality care is quality communication, and yet we know that this is tricky. We know that there's been a lot of science to show that if you look at the root cause of sentinel events, critical incidences in our system, if you look at those root causes, the #1 cause is usually communication. And if we were able to fix this, we would have fixed it already. Here's some of the reasons why it's challenging. There's multiple handoffs from shift to shift, professional to professional, team to team, organization to organization. We need to think about those transitions and handovers. We also know that all of our professions and all of our education, we've been educated to communicate in a certain way. Some professions are educated to be very succinct, get to the point, solve the problem, whereas other professions have been told be very holistic, give the full narrative of the patient. So now you get the succinct professional speaking to the holistic narrative perspective professional, and you've got a potential difference in communication. We also know the terms, the jargon, and the acronyms in all of our fields is immense. We use so many short forms, we have so many acronyms, and at worst, this can cause miscommunication when the same acronym means different things to different professions or different organizations. There can be clear safety issues. We can also see that some people don't always feel safe to speak up and ask what a term means because there is power, hierarchy, and stereotypes in our system. So many organizations look at this and say, okay, there's communication tools that can be brought in. Let's bring in a communication tool that will fix our team communication. And there's lots that have come up. Usually when I talk globally, the #1 that I hear about is the SBAR tool. So if I was with you in person, I'd ask for a show of hands of how many of you have been educated or told to use SBAR. But there's, oh, thanks, Kate. Kate's raising her hand for me. Yes, there's, Amo says as well, a couple more. Yes, so SBAR has been in and out of our system for years. And we're hearing again another resurgence for the wisdom of using this. Our organization, my center, is actually based in a large teaching hospital, Toronto General Hospital, and we now use this for every form of communication. If our elevator breaks down, if we have a medication change globally affecting all of our staff, we get sent an SBAR, which stands, as you can see on this slide, for situation, background, assessment, and recommendation. It gives a lovely structured way for people to communicate clearly, succinctly, and be understood. However, tools like this need a couple of things. One, there needs to be good education about the purpose of the tool. All staff need to be educated about how to use it and what the reinforcement is. And there needs to be continual reinforcement of that, because as time goes by, people find workarounds, or you have new staff join that are unfamiliar with tools. So tools aren't always the quick fix, but they certainly can support this kind of work together. We also have seen some lovely work with COVID to really help people understand who's doing what on the team. This is an example that we used across our country to help as COVID hit. to really start to identify under whose scope of practice and in what organization are each profession doing aspects of care for our COVID patients. And when you see this in a pictorial, I think it's pretty clear how complicated this can be. We have lots of different healthcare professionals doing the same thing. They all have similar and overlapping perspectives of care. So the magic for teams is role negotiation, is to actually talk about who's the right one to do it for this patient at this point in their health journey. And that can take into account people's advanced education or training, their seniority, but it also can take into account how busy they are on that shift or that week. So these kinds of tools can really help to support communication across teams and can really help with some of the details that teams need to work authentically and well together. Many of you may be interested and have expertise in quality improvement. And I've been really fascinated how we can use some quality improvement tools to help with our collaborative care. Many of you will be familiar with process maps, a very common and standard quality improvement tool. And I'm fascinated by how we can bring process maps with things like swim lanes that we can use per professional. So I know we have some pharmacists, including Neil Cottrell on here. So I chose to do a medication review and reconciliation on admission. And what we've done in this is tried to show pictorially all the different points that happen to a patient once they're admitted to hospital to support medication review. But you can also map out in these swim lanes which professions are doing which part. What a lovely way for clinicians to come together and talk about communication and talk about the role that everyone's doing, but also look for any ways to make changes to improve efficiency and effectiveness across the team. So those are some of the communication tools that we think are very helpful to our system. There's also some culture things that are really important to talk about. And to do that, I want to introduce to you, and some of you may be familiar with Google's quest to build the perfect team. So Google created a large project that they called Project Aristotle. As you know, Google is a large for-profit company, and they only hire the smartest and the best. Well, they put these smart and best staff together and asked them to create wonderful new innovations for the company. But it may not surprise you that all of these teams are not all equally successful. So they created this project to try and see what makes for good teams. Now, I know that Google, a big for-profit company, is not health and social care. And yet, when we've talked about this with many in health and social care to see the results, it resonates for them. And they say, yes, that does make sense for my system. So here's what Google found. The 5 top elements were: number 1, psychological safety. Team members need to feel safe to take risks and be vulnerable in front of each other. What that can mean for many in the healthcare system is to say, actually, I don't know the answer to that. The occupational therapist is the right one to answer that question. Creating more of that culture is something that I think is really important for teams to be exploring. The other results are equally important. They talk about dependability, that teams need to rely on each other to do what they say they're going to do and set a high bar of performance. But they also need structure and clarity. They need to know the clear roles, the plans, and the goals. What is that common purpose? There needs to be a plan. But there's also the personal elements of the meaning and the impact of work. So knowing that people trust and respect you and value your contributions to the system means a lot to staff. And that's part of the reason we hear, and as Kate shared earlier, why people are happier when they're working in collaborative environments and they're more likely to stay in organizations. So some of the key elements of psychological safety that we really think about, we love the work by Amy Edmondson, and she's from Harvard. Some of us have had the pleasure of meeting her, and she's spoken at a few of our interprofessional conferences. But she really talks about these kinds of norms or these kinds of ways of a culture to support safer and healthier teams. Wouldn't it be great if we felt all of these things on the teams that we work with? And how can we as leaders and as team members look for ways to improve this in the teams that we have? Because really what we're thinking about and talking about right now in our system is improving our experiences. The missing aim that has come up from the Institute for Healthcare Improvement is really talking about helping us to have joy at work, improving our experience, and ensuring that we have resilience and that we have a feeling of safety and trust. And that's where that link is really coming in for us in the field right now. There's some wonderful reports that you can use that help to give you some guidance. This comes from our American colleagues and friends who've developed a really nice summary for us on how to develop quality interprofessional education for health professionals. I like this document. It has a lot of great strategic and thoughtful ways of concretely doing this in our system. So I wanted to share that with you. And of course, all of my slides are available for you in a PDF following the talk. So how can we start to teach and really learn about this? How can we support this for our students and for our teams? Well, we're fortunate that many countries have developed competency domains. Our American colleagues have set 4 key domains that they talk about as being critical for both students and for clinicians. And they have got some really nice subdomains that break down what each of these look like. In Canada, we also have a competency framework, and we have 6 core competencies. 4 of them are very similar to the Americans, but what's different in ours is we have the bottom 2, which is collaborative leadership and conflict, dealing with conflict. My experience in the field and as a consultant for a number of years is that teams that don't deal with who's leading what and don't openly speak about conflict and what we will do when we have a difference of opinion, not if, but when, teams that can build in those key skills, that's when this really is sticks and is much more sustainable for organizations. So I really encourage you to look at this framework and to help to look at some of those specific nuances. There is a learning continuum. We really need to think about when this happens, and it needs to happen at all phases of development, from our early learners right through to those that have been in practice for decades, because we can expose our early learners to some of the key elements and the key contact, and then we need to immerse learners in it so that they can really understand and see more of the day-to-day work that we do. We need to support those that are getting ready to graduate and early grads with more competency levels of this. But for those of us in practice, it's hard to keep up with all the different roles, and the pace of technology and the pace of research is coming so strong that we need to look at continuing professional development for all of us. So I think one of the best ways to think about this work is to see it. So we love showing some video simulations. We've created a series of some new videos. So my UQ friends, I don't think you'll have seen this one yet. This is a relatively new one, and it's also in high definition. So hopefully a nice quality for you. So what you're going to see in this video is about 4 minutes, and it's a team that's talking about a safety incident that's happened. I wanted to frame this about communication and healthier and safer teams. So I've chosen this clip because it's talking about safety. What I want you to think about as you're watching this clip is, how does the facilitator and the team members support teams and teamwork in this meeting? How did the facilitator and other members of the team use questions to engage the voices? And how do you see psychological safety in this? And what are other ways that you can bring this to your teams? So Catherine, we'll ask you to show the video now.
Okay, just a second.
Okay, thank you. Good morning.
Good morning.
Thanks everyone for coming together to talk about Mr. Medeiros. You may not know that he had another fall again yesterday. Fortunately, he didn't sustain any serious injury, but this is 3 falls in the last 2 weeks, correct? So any thoughts on why he keeps falling?
Well, our residents are frequent fallers, and I wonder if this fall is due to the nature of his reduced mobility and other medical issues he has.
Yes, he does have many risk
Excuse me?
factors.
Pat, you look like you had something you wanted to add.
Well, I was wondering, could we not use the term frequent fallers? We use that term sometimes, and I feel like it's a bit of a label. I also worry that one of the residents or family is going to overhear us use that term.
Yeah, you're 100% right, Pat, and I'm sorry. I need to improve on not using labels and jargon like that, so it's my bad.
I think it happens to all of us, and so thank you for bringing that up, Pat. Why don't we just make that a group norm, that we do our best to avoid labels and jargon of that nature. But for now, let's focus on Mr. Medeiros. Why do we think he keeps falling?
You work with him.
I do my best to watch him at all times, but I do have 5 other residents I care for too.
That came out wrong. I know our personal support workers work the closest with our residents, and I know because you work the closest with them and know them the best, you might have the best idea.
Thank you, I appreciate that. I actually think one of the reasons he falls is that he's not getting much sleep at night. I noticed that on the days when he has fallen, he's been more tired, so maybe that's a factor.
Yes, I noticed in the notes he does seem to have fewer falls on the days when he's had more sleep.
Okay then, so why do we think he's not sleeping?
Well, he's restless at night.
So then why do we think he's restless?
Well, he is in the noisiest section on the floor. Perhaps we should move him.
I know Mr. Medeiros loves his room. It's his home. It's close to his friend, and he really enjoys their company. I could also ask him why he thinks he's not sleeping some nights.
That would be great, because it's really important that we have his perspective on this.
Yeah.
One other thing. I remember speaking with his daughter about a week or so ago, and she asked why we don't use restraints to stop him from falling. What does the team think?
Yeah, families often ask us about that, and as we know, the restraints can actually make it worse.
And you know, I did speak to his daughter about this earlier in the week. I'm just wondering if we need to organize a family meeting to clarify all of this.
Yeah, that's a lot of really important points. Why don't we think of it in terms of next steps? Let's arrange a meeting with the family.
Thank you, Catherine. That played beautifully. So we'll just go back to the slides now. So what I would love to do, I'm looking and seeing that we're, under 50 participants around. It would be lovely if there's some brave participants that wouldn't mind just sharing what they saw in the video, just briefly, what you saw maybe around how the facilitator and the team members supported their team and the teamwork. How maybe questions help to engage voices and ensure that everyone was able to share ideas, and what you saw around psychological safety and how teams can help to support and minimize blame. So I'll come off of the slides and just invite people if they'd be willing to come off mute and or come on video and just share what they saw or what they observed in that video.
Lynn, I just want to start the ball rolling, if I may, and
Thank
just
you.
say the big thing for me, and it's underplayed an awful lot, is they all listen to each other. They actually listened without being judgmental. And they didn't just listen, they responded to what was said. And I think that listening is something that we don't pick up on sometimes. So that's really important. So everyone was respected and they were listened to.
Thanks, Bernadette. What I love about what you said too is that we often use the wording that we want our teams to respect each other. And I often push people a little bit, what does respect look like on a team? And one of the answers could be that we truly listen to each other and that we don't judge each other or blame each other. So I think you helped to unpack some of that really nicely. Thank you for starting us off.
I was just going to add, my thing was the communication did look respectful, but I think their contributions, they felt valued because people responded to those and took accountability if they had, any negative influence prior to them talking.
Thanks so much. Yeah, you mentioned a couple of key communication things there that I really appreciate. Thank you for sharing. Aaron, I see you've raised your hand.
Yeah, hi everyone. So I really like the acknowledgement in there around the misstep. So there was a miscommunication of intent. So it wasn't the words per se, oh, it came out wrong. So I'm a practical boy and I like practical things, and those little takeaways are things students can really cling on to. So I found that quite a useful stimulus.
Thanks, Aaron. Yeah, I like your wording there of sort of missteps, because we know that's going to happen. So making it safe to say, oh, that came out wrong, or I didn't mean it that way, is really important. And as you say, some practical things for students and teams to see what this looks and feels like can really help. I want to acknowledge Naomi's nice comment in the chat. They picked up on nonverbal. So we've talked about verbal, but there's also all those nonverbals. The social worker was really watching something, the personal support worker, and could tell maybe he didn't feel safe to have voice, or maybe there was a power issue there. But by inviting him in, he contributed some key information. So thanks for picking that up, Naomi. Hi, Neil. I see you've got your hand up.
Hi, Lynne. Yeah, I thought one of the good things they brought up as well around the thing Aaron identified, they talked about we need to put that into our group norms. So they're establishing group norms of how the team's going to behave, how they're going to communicate. And obviously they have some group norms already established. By the way, they were all communicating respectfully, and when something came out wrong, very comfortable to acknowledge that that was not as it was intended. So it's good for students as well. We always get them to think about, you're going to be working in a team this semester. Let's think about the group norms. How are you going to behave within your team?
Excellent catch, Neil. Thanks for raising that and sharing that. And you know, when you need an example of how teams can work through conflict, going back to what they've already agreed on as their norms is one way to help do that. Because then they can pull back to say, we've already agreed that this is the way we're going to be. Let's get back on track. That can help in those sort of conflict opportunities. And Kate has added to the chat that it recognizes the participation of the family is important and the perspective of the residents. How many times does that become an afterthought, where the team is busy trying to unpack and come up with all the solutions without going to those that often know best, that should know best, the resident, the patient, the family member. So that caregiver and that focus needs to come out, and we need to emphasize that for our teams and for our learners. Well, thank you for playing with a wonderful debrief there. I hope that was a good way of talking around some of the ways that we can really support healthy and safer teams, because debriefing is so critical, and debriefing is really a team sport. The power of questions and the importance for teams to reflect and think about what this means for them, what communication, what roles, what errors, what have we done well as a team? Those kinds of process questions are really important for teams to build into their day-to-day meetings and in the day-to-day that they work on. We spend so much time on task that we forget about how we're working together. So these kinds of debriefings are really important for teams to bring in. So something you might be wondering is maybe you work in a uni professional space or have a really nice piece of education for students or for clinicians that's uni professional, and you might be convinced to think, how can I make this more interprofessional? Well, at the very root, I talked about the definition, which is about, from, and with. So if you can bring two or more professions together to explore about each other, learn from each other, and create a shared care plan with each other, you're moving something to be more interprofessional. It's important that there be interactivity. People need that chance, as Bernadette said, to truly listen to each other, to be able to engage and communicate with each other. So it can't be just coming in and listening to a speaker. There has to be some back and forth and some learning, that about, from, and with. And we need to be calling things out more. We need to be using language about collaboration. We need to be talking about shared purpose. Those kinds of terms and that language can really support the kind of culture that we're wanting to create in our systems. So some key learnings on our journey, some of the sustainability pieces that I mentioned earlier. This partnership really needs to be made explicitly. Education and practice must work together on this. I know many centers of interprofessional education or collaboration across the world that have not been able to sustain themselves. And when you unpack why, many of them were trying to do it in isolation, just to students or just in practice, but not truly together. We need to be sharing the narratives. The data is quite clear, but sharing the stories, and I would suggest coming out of the pandemic, that there are some really powerful narratives of success and that really highlight teamwork, and bringing that into our work and into our research, looking at mixed methodologies to really help to show what this looks like in practice. Using core clinical competencies, if you create simulations, making sure that simulations have core competencies that you want everyone to experience, as well as those uni professional skills that everyone needs. And then again, just emphasizing the importance of having our patient, client, and family, not just patient-centered, but truly as patient partners in the journey. So somebody mentioned, I think it was Aaron, said he's a practical lad, and I am too. So I want to make sure that I've given you some tools. So some of the tools that I've hoped to provide you with today is some of the evidence, the literature, and the best practices, some of the ideas around using competency frameworks, thinking about handoffs and handoff transitions. So thinking about what communication tools or technology is needed to go from staff to staff, but also team to team or organization to organization. So thinking across those communities. I think using video simulation is so important for learning. We can talk about this in theory, but when you get an emotional reaction and can see and feel it, I think it sticks for people a little bit more. Some key elements of psychological safety. If there's one area that I'm really interested in this field, it's this work. So thinking about ways that we can promote more of that. And then again, just trying to think you don't have to throw out great curriculum or great education. You can just tweak it to make it a little bit more interprofessional. So I hope I've been able to create some learnings for you, and maybe just reflecting a little bit, is there something new that you can take away from today that you could think about embedding in your teaching, in your practice, or in your research? And is there something that you can share with some other people in your organization? Is there a takeaway that you can commit and promise that you'll share with somebody on your team? That way it really helps to promote more and more champions and change agents in our system. This has my email address, and you're more than welcome to reach out if there's a piece of research or literature that you're interested on. I may know somewhere that you can go to get that. I'd also like to just share that for many of you may not know this, but we've actually just changed the name of our center. It just changed on Thursday of last week. We no longer are called the Center for Interprofessional Education. To truly talk about collaboration between practice and education, we felt we needed a name change. So our new center is the Center for Advancing Collaborative Healthcare and Education. So when you go to our website, you will see wording that summarizes this, and it has our new strategic plan and our new directions. So finally, a couple of resources that I shared today. And again, all of these slides are available in PDF for you. So you've got all of these resources. So I'm going to stop with the slides now and just come back and say thank you. Thank you for coming and joining us this morning.